Welcome to the Pulse Check podcast. We're your hosts. I'm Sarah.
And I'm Sammy. Grab your beverage of choice and let's get right into it. Our guest today is proof that nursing is never just one career. Mandy Christensen has spent the last 26 years reinventing herself within healthcare, from CNA to LPN to RN to Certified Nurse-Midwife and now Psychiatric-Mental health nurse practitioner. She's delivered babies, worked home health, floated through multiple hospital units, gone back to school more than once while raising 4 kids, and dedicated her career to helping women through some of the most vulnerable and transformative moments of their lives. She has stories that range from being chased by roosters during home health visits to running neonatal codes, catching babies, and now helping women navigate anxiety, depression, OCD, birth trauma, and mental health throughout pregnancy and beyond. If there's anything you learned today, it's that Mandy's career has been anything but ordinary. So grab your beverage of choice, settle in, and get ready for an incredible conversation. Mandy, welcome to the Pulse Check podcast. Okay, wonderful. Okay, Mandy, so just starting from the beginning, you spent your career helping women become mothers while you also raised 4 children of your own, right?
Yes.
Looking back, do you feel like nursing shaped motherhood more or motherhood shaped nursing more?
Well, I think it's a hard one.
Yeah.
It's hard because they really do impact each other so much. But I'm going to go with, I think being a mother impacted nursing more.
Okay, and how come?
Well, later on in my career with some mental health issues. It was when my children were struggling with mental health, I was like, I got to learn more. And then also I struggled as a mother with postpartum depression with some OCD features. And then that also helped me in my career to understand other people, what they were going through, and to understand other people as parents who have children having mental health issues, or even as I now take care of adolescents having some mental health issues. So being a mother to people or to children who have mental health issues really did impact me as a provider. And then as a nurse, I've never really had to think in my head, like, how would I want my child to be treated?
Right.
Like, I don't really have to do that. Like,
yes.
It's just something that...
It's natural.
It is a little
like
bit...
a mother instinct.
Yes, I don't know, but it feels like I didn't have to remind myself that, but I just know that this is someone's kid. And like, I remember taking care of newborns for a little bit, working L&D, but also cross-training to the back nursery down in Cedar City Small Hospital.
Yeah.
And like, even how you hold them, not that they're fragile, but this is somebody's precious baby. Like, even how you like talk to them and wash their hair under the sink, it's like, this is somebody's most precious baby.
Yes.
And so I think I may have been the same way if I hadn't had any kids, but having had my own children has really made me maybe more understanding and gentle to people, and as a nurse and as a provider.
Yes. Do you feel like it's hard to create that barrier between being a nurse or a provider and with your kids? Like, since they struggle with mental health, are you like always trying to not diagnose them in the way, but help them? Yeah.
Yes. Yes. I'm like, this is what's going on.
Yeah.
No, I think it's been, I actually, the boundary there is the actual treatment.
Yeah.
But it's been a really benefit, I think, to my family, the knowledge that I have working within the mental health field and knowing about the criteria, like for the DSM-5 about, okay, what are these symptom clusters mean?
Right.
Do we need to seek more care? And then getting that care and treatment for them, but it's not usually for me, but I at least can know where to go for them to get that care, which is a whole nother issue with access to care. And I feel fortunate that my kids who have struggled with their mental health have been able to get that access to care. And so I feel bad for those who don't have like some knowledge base, to be like, is this normal? And do they need help? And do they need help now? So I don't have a hard time with that. Like as far as like, it hasn't been an issue with my kids. I guess one of my kids is like, are you trying to diagnose me? And it's like, I just care about you, buddy. Like, this is what I'm seeing.
Right.
But again, these conversations now are with adolescent and adult kids, not, this wasn't when they were little.
Totally.
The conversations were different, but
yeah.
So maybe I am kind of trying to diagnose you.
Well, it sounds like knowledge is like the benefit.
Yes.
Right? It's just been so beneficial in your eyes, for
yes.
sure.
And normalizing like the treatment, medication, therapy, like that's fine. That's normal. This is what your brain needs, just like somebody with diabetes needs their blood sugar managed.
Yeah.
You need some of your mental health issues addressed and managed if possible. So
exactly.
Yeah. So it's been okay.
So knowledge has been your power.
Yeah.
I love it. the kids.
Okay.
Going on to your husband. You celebrated 25 years of marriage. Congratulations.
Thank
so
you.
exciting.
Thank you.
Most nurses know how demanding the nursing career can be, right? You have to balance your marriage, motherhood, night shifts, on-call schedules, especially when you're a midwife, right? Multiple advanced degrees. How do you feel like you have balanced all of those?
Well, not always very well.
Yeah.
But I think, I can't remember, I think it's Brene Brown was talking about, and she's I think she's a psychologist, but does research in relationships. She has a few books, like Daring Greatly. Anyway, she kind of, this referencing her, is that she often says relationships and having things be successful in your marriage is not because it's 50-50 all the time. Sometimes one person is giving 80, the other's 20. And so I think there's been that for Steve and I in our marriage, like sometimes he really is doing more than his fair share. And then, other times maybe it's the opposite and I'm doing more. So I think early in our marriage, thankfully, I was in nursing school, and my first job out of nursing school was as an LPN. So I guess I wasn't done with nursing school yet, but that between my LPN year and whatever. Was doing home health. But when I started working at Med-Surg, I did nights. So I did 4 in a row and then was off for 10.
Oh.
Okay, so that's 14 days. So it's part-time.
Nice.
So 4 in a row and then off for 10 and 4 in a row. And we had, my oldest at that time was a baby. And so, she had a lot of colic. Like, she was such a fussy baby.
Oh.
And
I hear that can be really hard.
Yes.
Yeah.
But he's taking care of her in the night for those 4 nights in a row. And
shout out, Steve.
Yes. And I think he actually, I remember, and this is the cell phones were different. You had like antenna. Like these are like older.
I don't even remember this.
Okay, so my oldest is now 22.
Okay.
Anyway, he would tell me about, he would put the car seat on top of the dryer just for and then we had only a battery operated swing, and the batteries just run through them because she was most content swinging,
like moving.
Yes. And then he would bring her to me some at night to breastfeed, like in the night, because we lived pretty close to the hospital. And so he learned early in our marriage that he needs to be a partner in parenting, and so it didn't ever all fall to me, and that kind of just maintained throughout our marriage. So in order for me to be able to work or not be consumed with trying to manage it all by myself, it worked because he was actually a partner to me.
Totally.
And continues to be. Like right now, things are busy at work, and so he orders the groceries. Like he'll meal plan and order the groceries.
That's a good man right there.
Yes.
Good man.
And then I used to do all the bills. And then now he does like a set of bills, and I have my set of bills so that are like on timers, or like programmed.
Right. Yeah.
So I think balancing and management is just like teamwork, and that sounds kind of generic, but it really is
that.
Yeah.
Yeah.
Yeah. And I assign the kids some chores, and they don't always do them, but it's like
everyone's picking up their slack.
Yes.
Yes.
Do your own laundry.
Doing what they need to do.
Mom is not in charge of all of our laundry in this whole house, and so they know that, and so I think everybody pulling their own weight once they can.
Yeah.
When they were little, of course, we didn't expect them to parent themselves.
Right. Yes.
But
to teach them still.
Yeah. And Steve was a great help. So
good.
That's what I think.
And it's not always 50-50.
Right.
It's teamwork. That's what it sounds like. Do you feel like there was ever a time where I guess you kind of felt like I can't keep doing this? Like it's a lot?
Well, yeah, I remember when Zach was 8, so he's my second oldest. I was working nights and on L&D at the time, and I remember coming home and he was still awake. It was the middle of the night. It was like 1 a.m. and I saw his light on in his, through the window of the front of the house. And I was like, what is he doing? And he's always had struggled with some insomnia as a little boy. Yeah. And then, I went down to his room and he couldn't sleep, and he was sharing with me some things, and I was like, I probably need to be home a little bit more. And that's one thing that I really loved about nursing, though, is I was able to go talk to my manager and be like, hey, I don't know if there is a position for part-time or at least like 75% time. but I need to drop down a little.
Yes.
And that was a possibility for me. And I know that's not always an option, but I feel thankful that there were times when I did feel like I gotta to find a little bit more balance. I do need to back off a little bit, and I know that that's like a privilege as far as some people have to work full time and they have to have the benefits coming from them. So I get it. But we were able to like just pull back a little and still be able to like make bills. But so yeah, I think trying to be as flexible as possible when it feels like I can't do this anymore, just like where can I make adjustments? And that probably is when Steve started taking over the groceries at some point, was one of these conversations. Like, okay, I'm feeling like I can't handle what I was handling, or this right now is super busy, and so what can he take on, or someone else, what could they take on, or what could I decrease? And so at the time, that's what we could do. So yeah, I think being honest with myself and communicating with my husband, and then like what can we change, and then really always trying to go to your leadership and being like, hey, this isn't working. Yes, this is what's going on. And honestly, I think they would rather work with you if you're a good worker, whatever that means, instead of having to orient and train. That's expensive.
Like somebody new.
Someone new.
Like, if they want to keep you around, they will.
I hope so. I hope that they would. I like that way of thinking.
Yes, so cross your fingers.
Yes. So yeah, my thought is, if you feel like you're drowning, that's a good sign to be like, hey, what can change?
It sounds like you've always been pretty good at communicating and like pretty self-aware. Have you always been like that? Like, or is that something you had to learn?
I would say I'm a good communicator, but I am pretty emotional.
Okay.
Like if I talk to the manager, I'm like, I wish I wouldn't have to have tears when I talk to you.
Yes.
But yeah, I think, I would say pretty self-aware and reflective.
Good.
Problem solver. Like I think
those are good words.
I think a lot of people with a similar personality as me tend to want things to be a little bit more efficient and are trying to think it through. What could we do better? What could I tweak here or there? And so, I would say definitely self-aware and thinking a lot.
Yeah. Which, sometimes comes with ADHD. Yes. I feel like I can relate to that. Yes. Okay, so just jumping into your career and kind of just building up where you are now.
Yes.
You've reinvented yourself multiple times, like 5 different times: CNA, LPN, RN, midwife, psych, NP, right?
Yeah.
What keeps you pushing to the next challenge? Because you just kept going.
I don't know. Like, I don't know if it feels like it was a reinvention, though. Like, it was like... so when I knew I had to be a CNN in order to get into RN school at the time, okay? So it was like, okay, well, that's what I'm gonna do. But I never was thinking, I'm only doing this so I can be an RN. I'm only being an RN so I can be a midwife. I'm only doing this which isn't a necessary step. You don't have to be a midwife before a second P, but that truly was never my thinking. It was like, okay, I did know I wanted to be an RN. That was the first goal.
Yes.
And we had the opportunity that second year of RN school of being like, do you want to just sit for the LPN board and then work through that next year or so of RN school? Okay. And so I chose to do that because I thought, we needed money. Like, I think Steve was,
right now.
Yeah. Steve was, he was detailing cars at a car dealership and making like crap, and we lived in, it was like, well, I could make a little more as an LPN versus a CNA.
Sure.
So that's why I did that. And then as an RN, I loved being an RN, by the way. I loved it.
Yeah.
I loved it.
Good. What made you want to become an RN from the beginning? Oh
no. I don't know. And I remember in high school, I wanted to be a speech pathologist and audiologist. I wanted to work with kids and do like special ed type stuff. Okay. So I think I've known for a while that I wanted to be in the helping field. But when we moved to Utah, I got a scholarship at SUU, just like a general, I think they were really just trying to diversify because I was out of state tuition because I grew up in Indiana. So I got the scholarship, but they didn't have speech language pathology and audiology as a major. It's a master's anyway, the pathway, but I was was like, oh, well, I'll just apply to RN school. Truly, I don't have any family member that's an RN that I know.
That's the next thing.
So I was like, okay, well, let's just do that. And I really loved being a CNA. And the LPN, I did some home health, and then again later as an LPN or as an RN. And then, but with RN, I love the diversity. I did med surg, and it was small hospital, so it was age like 28 days old and older.
Oh.
It was anybody who was admitted to the hospital.
Exactly. Yep.
And that was kind of exciting.
Yes.
You know, just be like, what I got today.
The thrill.
Yes.
Mm-hmm.
And so I really liked that, and it was with Intermountain, and the staffing ratios were pretty good. Like,
sure.
So I really liked it quite a bit, and but it was probably not until I started having like my babies that I was like, you know what, I want to do more. Like I started doing L&D, and I was like, you have more options here, sis. You don't have to lay on your back if you don't want to.
Right.
Like,
yeah.
You don't have to. Like, you know what I'm saying?
More. Yes.
Yeah, I mean, I'm not saying you have to be like super granola here. I'm just saying you don't have to sit like that.
Just sit there.
Yeah. You can lean back, and we can like roll to your side if you want. It just felt like there was more that I could offer. I don't know. I felt like I wanted to do more. Yes. And so I applied for midwifery school.
Okay.
And then, I don't know if you want me to.
No, that sounds good. Yeah.
So it was never like, I feel like it was just adding on. So never like a reinvention. It was like, because I still do right now. I feel like I still do what I did as a CNA. Like,
oh, sure.
Bedside care, and just helping people with like their self-cares or ADLs. Like, I feel like that is still something, if I am at the hospital delivering a baby, that I'm still like, I'll do some of my role is as a CNA. I'm cool with that. Yeah. And then as an RN, that teaching, a lot of teaching as an RN, but also
educating the patient for sure.
Yes. And
I
I loved that. Still do that. And so it didn't feel like a reinvention. It's just more knowledge or information.
Just getting more and more.
So I could like be able to help more. It was always like there is something that I could help you more if I had the knowledge.
Sure. So let me get that.
Yes.
And I'll be back.
Yes. Exactly. Yeah.
Okay, that totally makes sense though, which is amazing. Oh, you have opened up to me about how when you were caring for a resident when the second plane hit on September 11th.
Yes.
What was like the vibe? I guess the vibe is not the correct term.
No,
but like the feeling in the room during that time.
Right.
Because did you see it on the TV?
Yes. It was live. So
gotcha.
this is a long time ago now.
Yeah.
This was actually, I was working as a CNA. By the way, one of the hardest jobs I've ever had in my life is a CNA. Okay. Like,
relatable.
Just so hard. Long shifts, and am I gonna pee? I mean, that still happens as an RN, but like just run ragged and feeding people and bathing and anyway. Yeah. But I liked it. And anyway, so this man, COPD, had lived there for a while in this unit, and I remember we had just done cares where into the bathroom, like he had shaved and was getting him back in bed, and I remember his TV was on, and in the bottom corner it says live, like
like the little red, the little red thing. It says live. Yes.
Mm-hmm. And it's a small, it's like these old, flat screen.
It's like a box.
Yes. And there's two people in his room, by the way. Like there are no private rooms here, but I don't even remember what the other person was doing or if they were even there. But I remember both of us, like, I don't know if I was putting lotion on his back or I was doing something with his back, but we could both see the TV, and like we saw the first plane, like they go.
Oh my gosh.
And then it was like, I think mostly it just felt surreal, like, is this real? And and of course at the time so much has evolved as far as who was it, like what was the motive, and then but so actually seeing that second one was like, oh my goodness. And then again, this is back, not a lot of cell phones. It was just like, what is going on? But truly wanting to talk to family that night, like calling my family back in Indiana, even though they're not close to the Twin Towers, but just that like coming together, it felt like everybody was concerned. Like this felt so vulnerable to have that happen in the U.S. And so I just remember it being just seeing it with him and us both being like, what? Like is this happening? Yeah, I do remember that. Yeah,
just it not even feeling real.
No,
I can't even imagine.
Yeah,
that's so scary. I feel like I would definitely be calling my family too.
Yes. Yes.
Okay, so you've practiced long enough to remember nursing before that barcode scanning with like, the security measures of making sure we're giving the right meds to the right patients.
Yes.
I guess, like, what did nursing teach you back then that newer nurses might be missing today?
Well, I don't. Because, I don't know. I think, what do you think of this? You tell me, because you are younger than me as a nurse. But, like, okay, so we were supposed to do the 5 rites, which now is it like 6 rites or something? It's a little different now?
I think it's like 10.
Oh, okay, well, for some reason the 5 rites is coming to mind, but whatever. Yeah. So maybe that's why I made an error.
It's okay.
Okay.
Yes.
But a few things though. When you go into a room, you have this like handful of meds, and they were not. There's no computer in the room. Especially, I'm thinking of a specific job in Indiana. So this is pregnant with my second baby. Would move from Utah, and I'm working med-surg. Mind you, this is not a big chain. 10 patients to one nurse. 10 patients.
Terrible.
So bad. One had just stepped down. One had just stepped down from ICU, and one was admitted from the ER with chest tube. But I had these 8 other patients.
Yeah.
And so this night specifically, I remember it. And I have my handful of meds for Betty Lou, or whatever her name was.
Sure.
And rooms were mostly not private. Like there was a couple that were individual, but still 2 people per room.
Oh yeah, buddy system.
Yes.
Sure.
So it's night shift because I did a lot of nights, for better or worse. And so I go in and give her meds, and later realized it was the wrong person. We'll talk about that in a second if you want. But
I would love to.
But I think that was, I remember very clearly a few of these mistakes because I'm pretty conscientious anyway. And so like the feeling of making an error, okay, so error is human, but like
gut wrenching.
Yes.
But your body takes over.
Yes. Like, oh my goodness.
Get hot.
And then, like, I gotta call somebody and admit it. I just did this, and anyway. But I'm wondering if at the time, not with this specific patient, but knowing that I passed, lots and lots and lots of meds as an RN, but just touching them and their bracelet, looking them in the eye, tell me your name and date of birth. Whereas now so much is computerized that a lot of times, like my dad recently had heart surgery about 2 years ago now.
Yeah.
So much is computer facing, and then use the barcode and then give him his meds, and they're the correct meds for the right person, the right time, blah blah blah.
Yeah.
But did we even look at Dad? Or
exactly.
Maybe not.
Did he take his blood pressure? We're giving you a blood pressure med. Did you know it's okay?
Right. Like, did you, and like even the touching, not that everybody wants to be touched, but there is some healing and connection with that. Like, when we see your bracelet, and we do have to scan their bracelets now, right? But still, like, getting it to where you can actually, I don't know, you must like
turning it around and then like looking them in the eye and like forming like, tell me your name and
yes.
Like not a crazy perfect connection, but enough where you're like, we know each other. We're good. We're connecting. I'm your nurse. You're my patient.
Yes. And I still think that the same principle is there now too. Like, okay, this is your lisinopril. Like, and you're taking this for your blood pressure, kind of thing. Like
teaching.
Yes.
Yeah. Education, kind of.
Yeah. And sometimes. I think when that stack was in your hand, you're just like, okay, this is your lisinopril, this is for your blood pressure.
Totally.
And this is your potassium, and this,
Yes.
Whereas with it all computerized, maybe that's not happening as much, but I don't know, because I haven't passed a med in a long time.
Yes, girl. I will have to say, like, I totally agree, because when I go into a room, I have a phone with me, and I scan their barcode on their arm, and then I scan all the meds.
Yes.
But, like, what I try to do is, like, while I'm scanning the meds, I'm also, like, facing them, and also, like, asking them, like, how they're doing while I'm, like, going through this, and then usually, sometimes I totally forget, but I'll have, like, their pill full of just, like, cup full of pills, right? Yes. And I'm handing it to them, and they're like, oh, which one are all these again? And I'm like, that's my bad. You're right, you don't even know me, and I'm handing you a bunch of medications right now. And I'm like, yes, this one right here, and then I'll like go through a whole education, which is great when you only have like an hour to give medications to like 5 people.
Right.
But it's fine.
Right.
It's totally okay. Yes. But I totally agree, like the connection does seem a little lost sometimes.
Maybe, right.
a lot of the times, like, I'll even go there in the room, check on my patient, put gloves on, and I'll be like, I'll go up to my patient and I'll shake their arm and be like, hi, I'm Sammy, I'm gonna be your nurse tonight. And I'll like make eye contact with them.
Yes.
And then just so they know, like, I'm not there just to give them the cold shoulder, not there to just give them meds and do a little assessment.
Right.
I'm there as their caregiver for that night.
Yeah.
So
that's fun.
I think that I totally agree with you that a lot of that has been lost. But let's talk about the what?
I said there's workarounds, like you do. Like anyway.
You gotta just, I guess, put in more effort for it for sure.
Yeah.
Okay, let's talk about those errors.
Okay.
I guess the medication error, the patient with the chest tube.
Yes.
What happened? What happened with it? And like, with that being said though, I mean, like, just by your reaction, a lot of nurses like don't like to talk about their mistakes.
Yeah.
It's kind of frowned upon to talk about, but I do feel like with every nurse, everyone experiences a mistake.
Yes.
It's just gonna happen.
Right.
So talk about yours.
Yes. Okay. Well, I'm going to tell you a little sidebar about this. After I realized that I had given this patient the wrong meds, and thankfully it was not like a digoxin, or like it was a potassium, which can be dangerous, if they're depending on their potassium level. Seemed like there was one other one that was like, that's not great, but I didn't have to end up doing a lot of extra monitoring afterward. But so I go to my charge, and the reason I'm wanting to bring up this part is I still know that woman and think very highly of her. Like right now, if I went to Indiana to visit my family and I saw her in the grocery, we would probably hug. Like not because of that, but that did strengthen the relationship, because her reaction to it was like, oh honey, okay, what did you like, let's go through this.
And that's the best charge right there.
Yes,
that's the best charge right there.
And then she stands next to me as I am calling the doc, and because that's hard,
making you feel comfortable.
Yes, it's hard to like admit to the doc, who I had come from a hospital in southern Utah that had some orthopeds on that med-surg unit that were just brutal. Like just ripped you up and down. And so I was already kind of a bit insecure about talking to docs anyway. But to have to call them and not ask for an order or like update them instead, it's like, so I, gave your patient the wrong meds. Like that felt like such a failure. But so she stood next to me, and then he was actually awesome too. He was like, okay, what was her last potassium level? And I had looked that up before I called, and I was like, and he's like, she should be fine. And then I can't remember, like I said,
got a little extra in her system.
Yes, that's not gonna hurt her. And anyway, I just remember overall, even though it felt terrible to have made an error, that I had good support, and it wasn't a horrendous outcome, and sometimes that does happen, that it is a bad outcome after we make a mistake, but really trying to go back to, I am still a human. I do see that in that situation, night after night when I worked, overloaded, too many patients, and so now it's nice that some hospitals, hopefully more than not, have some ratio rules and have to scan the meds. There are some things in place to make things safer, like as far as med errors and being able to take good care of patients and not miss things like plugging in the chest tube.
Easy mistake, by the way. I understand it, especially when you don't work with chest tubes often.
No, I was like, okay.
It's so confusing.
Yes. And then that morning, the surgeon coming in and be like, the chest tube is not. Now listen. Now, did I see that the patient was like breathing well, not short of breath, color was?
You were in your checkups.
I mean, he's fine. He didn't need it anyway.
Yeah. Maybe I healed him actually. So he's cured.
But that was hard. It's hard to make mistakes, but I do think it made me, sometimes I think it's hard to be really extra conscientious, but I think it does make me a little bit slower, because not that I check 10 times, but like I am going to make sure that I am like double checking like insulin. I gave too much insulin once.
Well, that's so important to check. Okay, because you can kill somebody.
Yes.
That's when you gotta double check.
Yes. So So like, and now that is like an absolute. Where before it was like, yes, I mean, you wanted to. I'm just saying.
But you're just slower because you're checking more, which, like,
yes.
I do feel like a lot of the nurses I even work with, maybe double check, you know?
Yes.
It's smart. It's smart to do that. It's just making sure that you're giving the best care. You're not hurting your patient. You're not harming them in any way.
Right.
It doesn't hurt to maybe question everything you're doing.
Right. Which when then as a Psych NP, I'm like, okay, are we tipping into some, compulsive checking?
Yes, like OCD a little.
Yes. But like I do feel like it has made me more conscientious.
Yeah.
And I would say I also now I like to participate in creating protocols that are evidence-based. And I would say if I like having as a provider now, not as a nurse carrying out orders, but as someone who writes orders, I like the group practice and a midwifery practice because you kind of have another set of eyes on the management.
Right.
So that's
super
nice. Yes, very good. And you also have someone to also consult with, like, okay, this is my thinking based on this is what it says on Up to Date. I remember this from midwifery school, but maybe the evidence has changed and we really making efforts to stay up to date on things. So that type of checking now is okay, I'm checking the app to make sure this is up to date.
Right.
And I'm following protocols. And so I even like to create some protocols just so we're all on the same page. And then
extra safety measures.
Yes. And then for the psych, I have an app, and a lot of it, after a while, you just start to know the meds and what meds interact with what, and the CYP and all these things. But I do like to pull it up on my phone, an app, and then I go through it with the patient on a few side effects to watch for and stuff. And I don't know, I think that also keeps me just really thoughtful about med choices. It's not going to be like, she's going to get sertraline. It's like, okay. Right. But I know that can cause increased GI issues. Do they already have GI issues? If they already have GI issues, let's do something that's a little more gentle. So,
I do want to say, even with that, when I was your medical assistant, I learned even so much from you doing that too, because you would explain it to me, even you weren't even trying to explain it to me, you were just talking out loud. But I was going through nursing school at the same time. So I would be listening and I'd be like, oh, antidepressants can cause low libido, all these other things, and I'm like, oh, propranolol, let's help with heart rate. She's probably gonna give that if they're going for a weekend with their family.
Right.
Just stuff like that where it's just gonna, I don't know, it was really cool. So I think what you've done with the education, I think that's really smart and really good.
And so maybe it's from making errors.
Maybe
it's a combination of things, just wanting to do the best I can by the patient and feel good at the end of the day. I tried to operate with the best evidence and the best care that I knew how to give. So.
Well, I totally get, and especially I guess sounds like with those errors, it has made you even a safer nurse today, a nurse practitioner. You know what I'm saying? So
I do think so.
Errors, exactly. Errors make you safer, so they're just gonna happen. You gotta accept them.
Yes.
Okay, so jumping back into labor and delivery, you kept getting pulled back into that.
Yes.
Even to today. Right?
Yes.
Even when you took a little break off from it for a little bit.
Right.
What was it about that specialty that you feel has kept getting you pulled back in?
Well, I think another way to answer it is as a Psych NP, there is a demand for Psych NPs, and so I've had several job offers. Sometimes people just maybe it's LinkedIn and that's more generic, a recruiter, whatever. Sure. But it may be my friend's dad is a psychiatrist and they're looking for someone to help with their PHP for youth, okay? Or when I did some training at an inpatient unit, they needed some help there with their adolescent unit. So I do like adolescents too, okay? Yes. And then Center for Change, eating disorder facility, are often needing someone who can do psych and medical, okay? So I have these opportunities, and then even recently, come down and just go work at our general psych clinic instead of being integrated into this OB practice. Sure. And I resist that. I'm like, no, this is where I want to be, is with women who who are in this stage of life of having babies. Like, do I want to see some adolescents? Sure. I absolutely, like, I like that. I still like treating eating disorders. I like the perimenopausal transition. I'll really see anybody. Yeah. And it interests me. But
you have a favorite.
This niche, this group of type of patient who is in the thick of it, trying to get pregnant, or they've had a loss, or they're trying to conceive. Well, it's the same thing as trying to get pregnant, or they are pregnant, they are postpartum. That is just, I'm drawn back to it, and I don't know what it is. But I did a delivery. It had been about 6 months that I had done a delivery recently, and it was so fun. Like, I don't know what the word, first of all, unmedicated. She wanted to go unmedicated and was like, starting to be like, I don't know if I can do this. And I'm like, I hadn't given labor support in a minute, so I'm like, oh, I'm fresh. I'm like, oh, girl. Yeah. Let's do it. Yes. I'm like, all right, well, let's try a few things. And they're like, okay.
Get on your hands and knees.
In fact, I'm like, we're going to use a peanut ball. You're going to hate it. We're going to use peanut ball. 2 contractions.
I remember grabbing those all the time. I'm like, where's my peanut ball?
Yes. And I'm going to give you pressure on your back. And then, she starts to shake. Like, all these, for the provider, it's like riding a bike. Like, you're starting to see all the patterns, and it's about to happen.
Yes.
And then by the way, I don't deliver babies. Like, how midwives usually say they catch babies. Yeah. Okay, so she's delivering herself. Yeah. I am just, like, supporting her.
Yes.
So, anyways, it was just so fun to help catch her baby, put that baby up on her chest, talk her through, that was
good skin to skin.
Yes.
Lovely.
Delayed cord clamping, and then afterward, they're just so in love with their baby, and I got to be a part of that. It's freaking awesome.
That's so amazing.
So, and I know it's not all, like
butterflies and rainbows.
That's the word.
Right?
I was like,
yes.
Bunnies and bunnies and butts. But I think it is. I think it's just it is just a privilege to help women, to be a support to them, and just to kind of be a part of that. Right. That experience is awesome, and to know it. I think once you do it for a while and it just feels like, I know, we're good.
Yeah. Do you feel like it gets into routine?
No.
No. Like, it's always different. Always switches up.
Yeah. I mean, there's a general pattern. How labor goes. But it is something that still keeps us humble. It's not something you can totally time down to a T. It's not like there's going to be something that's going to maybe throw you for a loop. Maybe it's a beautiful unmedicated birth and then she hemorrhages. Yeah. Or maybe I don't know, just some stuff that everything seems
like
low
a baby's
key.
Heart rate dropping.
Yes.
Yeah.
Yes. And that's not a great feeling at all.
What is that feeling? Like, can you feel the feeling in the room? Like every healthcure provider that's in the room is sensing it and feeling something.
Yes, but there's a difference between the heart rate is down during a contraction and it's coming back up. Okay, right. Then the brain goes to, as you have more experience, we're going to reposition, we'll turn on pill, bolus, what are we going to do to kind of resuscitate this baby or give it a break? And I think sometimes there's more discomfort depending on who's in the room, the staff, how comfortable they are with me, or with just being in there with heart tones that are a little, category 2. Indeterminate, how are we? Yeah. So if I have done everything that I know to do and we're still not recovering, that is not a great feeling. But I've always had great backup with my docs that they know when I have somebody in labor, first of all. They know when I have somebody admitted, and that's been at both practices that I have worked at, and are available to me. I've never felt ghosted or left on red, good luck.
Thank goodness.
Never.
Yes.
And I know that can happen. But if I didn't have that scaffolding like that, okay, if this happens, I don't have a reliable way to get that woman and baby safe by proceeding with a C-section or forceps, or that would be awful, and thankfully I work in groups and in a profession where we have a pathway, this is what you do next. We've tried all these things. Doesn't mean it feels good. having to escalate, and sometimes there are bad outcomes, but usually not. Like usually you have it. You have the plan.
Yes.
If this goes on for X amount of time, or if we're not improving, then this is what we're going to do next.
Right. So you always have like a plan B. Whatever happens, we know what to do next.
Yes.
Which is good.
Generally. Like a general
like most
idea.
of the time.
Yes. You know what I mean? Like some stuff though.
Yes. It's like, whoa, what do we do now?
Yeah.
With that being said, like talking about how these births aren't always butterflies and rainbows, right?
Yes.
You've definitely had to go through some hard deliveries or things that don't turn out how you wanted to, right? How do you, I guess, go through that and then come back the next day? Like, how do you recover from something like that?
Well, I think, even as a nurse too, right?
Yeah.
Like you'll have, I remember taking care of a nurse, as a nurse taking care of a patient, this is back in Utah, and overnight, over my night shift, she had passed away. I was a time I was working 2 days back to back, and she passed away in the night. And so that outcome wasn't like on me per se, but the mental review of like, okay, is there anything that I missed or did? And so that same principle applies with, as the provider, if you have an outcome that, and it may not have been something that was really a negligence thing, and usually it's not. It's just this unpredictable nature of a heart tracing, or maybe the tear was a little bit worse vaginally, or in the perineum, because maybe the little hand was presenting under the chin, and it just made the diameter, bigger, needed more room to come through. Nothing really I could have done to change that, but the mental review is something that you can. It's good to do some review, absolutely, because that's how you can, make some positive changes in the future. But I think the other thing that makes it so that you can and do continue to come back is just having support at home. So my husband knows much more about birth and PIT and like psych meds
probably the average
than the average person, because I'm a talker, okay?
Yeah.
And so
No, you're not.
So that's how I process, is like, but
talking things out.
Yes. But then also having someone to talk to, like one of your partners in the midwifery practice, or a mentor, like that's a doc or another midwife who maybe is not in your practice. Like, here's this scenario, and so it's a part of processing it, and it's kind of like the charge nurse I went to when I made a mistake. Like, I still came back on my next shift, even though like tail between my legs in that case. Like, I'm the one.
I'm still here.
Yes, but I felt so supported by the doc and the nurse that it's not so shameful or scary, because we did it, we approached it together, we've reviewed, so I think the support of other people makes it so you can come back. And then honestly, I don't want anybody to have some sort of complex, but just being prepared, like for a resuscitation. As a midwife, I don't do resuscitation. It's now going to be more the nurses, RT in the room.
Right.
But when I did a resuscitation, when I was a nurse with a shoulder dystocia that was prolonged, and this baby came out, and the first APGAR was like a 1.
Oh.
And so
For those who don't know what that is, that's very low.
Yeah, that's
very low. That's not good.
And small hospital.
Yes.
So, it's me and RT, and, the midwife is doing the repair and like wanting to know how the baby's doing. And I'm trying to get the chest sterilized by making sure the baby's bagged right. And, I think, paying attention to NRP or your ACLS, or like, if you can, I'm not saying you have to know everything by heart, but some of these emergency scenarios, like running through those, there's like mock codes.
Oh, like mock trials, or not like trials, but codes.
Yeah, mock codes. Like, so postpartum hemorrhage, participating in those, like, okay, we're going to do this. And then shoulder dystocia, okay, we're going to get on this side of the bed and give suprapubic pressure from this direction.
Right.
Or like just knowing what are the next steps, so that you don't like, what am I supposed to do right now?
Exactly.
Yes.
Yeah, just like sit and stare instead of, I guess, what is it, like fight or flight?
Yes.
Like, like just, I don't even know, like just stare at it, or like actually do something about it.
Yes. And so being prepared, and then once it's over, like reflecting what could I have done better, and then also what went well, and then having people to talk to, somebody to just listen, and then another mentor type professional who knows it, who can give you feedback, and really just be that support when it was a difficult case.
Totally. Okay, so that's so good. So just like being able to talk it through. Do you ever like go home and like take a bath, or get your favorite food, or like is there stuff like that? Like comfort measures that you do for yourself?
Yes. Yeah. I think it's kind of changed over the years, but
I'm sure.
now that my kids are older, I'm not like
Yes.
coming home to them needing something most of the time.
Which is
But
nice.
yeah, like baths are like many things. I got like a bath table, a
Oh,
bath pillow.
That
Like,
sounds wonderful, Mandy.
yeah,
Yes.
yes.
So good. No, I think that's one of the things that you also taught me while I was your medical assistant is that, because I remember telling you a crazy story from one of my clinicals, and you were like, did you go and tell Keaton about that? And I was like, no, like I didn't tell him about that. And he was like, I think you should. Like, I think you need to talk about it. And I was like, good point, Mandy. I totally should. And then I told Keaton about it. He was like, wow, that's so crazy. Like, I'm so sorry you had to go through that. And I was like, thank you.
Yes.
I was like, you're right. Like, that was hard. Because I think it's also easy as nurses to go through something hard and then just push it to the side. Like, that's something that I normally do, is I just put up a wall and just try to forget about it.
Yeah.
But that's just not healthy either.
Right.
So.
Yes. Yeah. Ideally,
Yeah.
we'd have mentors and, time to debrief afterward, and when it's a super hard day or case. Yeah. I guess the only thing with talking with my spouse and you with Keaton, is, like, I never, and you don't either, but like, this is the patient's name.
No, exactly. No,
This is where they live.
HIPAA still stands.
HIPAA still stands. This is just a scenario.
Yes.
That happens somewhere in the world.
Yeah, we'll just say like Deborah. We'll say her name's Deborah.
Yes, Deborah. Yes, I had a Deborah day.
Yeah, exactly.
Yeah, exactly.
No, so I totally understand.
Yeah.
Okay, so going into pregnancy and kind of like what happens after you give birth, right?
Yes.
So during pregnancy, estrogen, progesterone, highest it's ever been, right?
Yes.
But as soon, like within hours after the delivery, it just plummets.
Yes.
Like pretty much to zero, right?
Right.
What is kind of happening in the brain during that hormonal shift?
Okay. So as soon as the placenta comes out, actually, is when it triggers a cascade of events in the body to increase prolactin in the brain.
Okay.
So as soon as the placenta releases, prolactin is going to increase, which makes it so the person can make milk. And so in order for prolactin to be elevated enough, it suppresses down that estrogen and progesterone.
Okay.
So those things are low, prolactin is high. So we see, like, functionally, why does that need to happen? So that, as far as like survival and evolution, you gotta feed her baby.
Yes.
However, we do know, and this may be, you may be like, duh, Mandy, but I didn't realize that the female brain has estrogen almost in every part of the brain. Like, I thought estrogen was like in my ovaries.
To be honest, that's what I thought. I thought it was just down south.
Yeah, yes, right?
I did not know it was up north.
Yes.
Yeah, that's crazy.
But what we do know is, and this is why this matters in the context of the female sex hormones. So before you have your period, so PMS type symptoms or PMDD, premenstrual dysphoric disorder. That's like the week before you start bleeding, maybe a few days in. People may feel like an exacerbation of pre-existing anxiety or depression, irritability, or maybe they don't experience it at all except for during that first week before the period. During puberty, we often are tagging young females as hormonal, moody, but here in a sec, I'm going to get to why. Okay? And then perimenopause. Perimenopause is that time leading up, can be as much as 10 years up until the time of menopause, which is you haven't had a period in 12 months. That kind of marks menopause. But leading up to that, what's happening is like this fluctuation in estrogen in the brain. And why does it matter as far as mood, anxiety, depression right after the baby's born? So what we know is in the brain, I kind of think about how certain groups of kids maybe run together. Okay, like they're like this group of kids are gonna go to, there's a whole bunch of them that are at the movies together, and then they're gonna walk to get ice cream. And then, okay, so this group of friends is progesterone, or estrogen, progesterone 2, dopamine, serotonin, norepinephrine. So the monoamines, those are the neurotransmitters, run closely in the brain together, like running kind of in groups. with the estrogen. And so when estrogen falls, those other ones kind of run with it. They're like, okay, and we're getting pulled down too. So estrogen falls, it's pulling with it some serotonin, dopamine, norepinephrine. And those are neurotransmitters in the brain that really support our mood, mental health. Okay, so we're having that falls. And then, so it's like, ooh, I don't have, maybe I wasn't feeling anxiety or depression, but now physiologically something has happened in the brain that makes it more likely because there's less of that neurotransmitter firing in the brain because estrogen fell.
Right.
And then the other thing that is kind of survival of the fittest type thing with women after you have your baby is this heightened threat scanning. So just think about, I'm not trying to like reduce us to mammals, but like if you think about from years and years and years ago when there was threat that something might hurt our child, you want to be protective of the child, and if that's like a panther.
Sure, yeah.
A panther.
Like a cheetah. Like a
cheetah.
threat instinct.
Yes.
Always aware of your surroundings.
Right. So it's slightly heightened, and so as like you want to take care of your baby. So it comes to mind this day and age is like other threats, like, well, what if somebody kidnapped my baby? Well, what if my baby gets sick, gets the measles, because measles is going around and I'm not vaccinated.
Every scenario.
Yes, so scenarios like threat scanning. Oh, and that could be it. And I can't go outside because they might catch a cold or there's too much smoke, and then they can't breathe because they're getting too much smoke in their system, and they're going to develop asthma. Like the brain is just a little bit more on guard, and so that's gonna exacerbate things too for mood. So yes, physiologically things are changing in the brain that may make it a little bit more likely that there's going to be an anxiety or depressive episode that follows. Sure. Not for everyone, but it's just kind of, we know that it's kind of set up that way that it is a potential. So we want to be aware, normalize some of it. Like, okay, this is what you're going to expect. The first 10 to 14 days, you may have baby blues, which is up and down emotions. As your body is adjusting to that, that is really going down.
Yes.
But if you're persistently feeling sad, anxious, overwhelmed, the threat scanning is keeping you awake, then it is developed into something more than just baby blues.
I was going to ask, how do you kind of decipher the differences between those baby blues, which I feel like I do hear a lot from a lot of moms where they're like, I have a healthy baby. I should be the happiest that I have ever been.
Yes.
But I'm just feeling this type of way and I can't put my finger on it. I don't know why. So how do you kind of not even diagnose, but just decipher between the baby blues and postpartum depression and anxiety and postpartum OCD? Right.
Okay. So a good interview is helpful, a good discussion, like just talking a little bit about, if I'm hearing a lot of shoulds, like I should be doing this, I should be doing that. So I'm hearing a lot of shame. When I think of shoulds, I think of shame, she's shooting on herself.
Yeah.
So it's like, why do you feel like you should do that? So managing some expectations. Are you expecting perfection? Or is that a realistic expectation that you feel like you should? So in that case, maybe some CBT, cognitive behavioral therapy, or just reframing some of her thoughts is going to be helpful for her, and some more support.
Good.
She's feeling like she needs to be the only one that feeds the baby because she is breastfeeding and that's her job.
Right.
And so, but is that true? Let's push against that narrative and be like, could you pump a bottle? Or if you don't have enough milk supply yet or you're exhausted, could you do a bottle of formula and have your partner wake up with the baby so you can get a 4 to 6 hour stretch?
Right.
And so just kind of thinking, what could we do to kind of push against this narrative that it has to be all you that's doing it? So if, however, they have quite a few supports in place, they are getting some good sleep, good chunks of sleep, they have been working with some of these kind of reframing some of their thoughts, and they're still suffering with quite a bit of what if scenarios. That would be the anxiety side of things, lots of what ifs, or can't sleep because of problem solving or thinking of what if the baby might die of SIDS. And so let me just go check real quick.
Yes.
And let me go check again. And then let me just turn on this monitor. Oh, I'm going to get a better monitor. the better screen. Oh, I'm going to get it so I can go to my phone so I can watch the baby all the time. So the obsession is I'm worried about my baby, and then the compulsion is I am compulsively needing reassurance that my baby is alive.
Right.
And so now we're starting to get into this is not, this is maladaptive. Like, this is not helping you. It's actually keeping your world small because you were consumed with this baby having SIDS.
Right.
And do we need to care about SIDS? Yes, back to sleep. Don't smoke with do the things we know, but are we going to be able to have certainty and prevent SIDS in all cases?
Right.
No, but that's a hard thing for women to hear, Yes. So you just approach it
kind of like reaching the boundary of like what's taking away from your life and like what's kind of benefiting you.
Yes.
Okay.
Yes. So a lot of women actually will have depression downstream from this anxiety, meaning, so maybe they present and they say, I am just so sad. I am crying all the time. And then as you get to talk to them, it is what's feeding that sadness is some hopelessness, and this worry is feeding it. So let's say she's afraid, which would be a theme that her baby is going to become sick with, let's use the measles, because that's been a common one that I'm experiencing with moms. So they're worried that the baby's going to get measles, and so they start to not go places because they want to protect the baby from a potential exposure. So they're not going to see friends, they're not going to the grocery, they're not going for walks because what if a stranger comes? No, I'm serious. Yes. What if somebody, like, as they're walking by, they cough, or what if they want to bend down and see my baby and it's in their breath? Like,
oh shoot.
Yeah. So this is so disruptive to their world, and really so hard because they want such reassurance that this baby isn't going to have measles that they're avoiding.
Right.
Now they have become more recluse, that they are sad, or they're sad about the future. Like, I can't control this measles. And so it becomes hopeless. And so not all postpartum depression is downstream from anxiety, but if someone is telling me that they're depressed, I want to hear more. Tell me a little bit more, like, what do you think is fueling that depression? And sometimes they're just like, I don't know, but I cannot get out of bed. I am just like, I have no motivation. I'm just
can't
depleted.
Do it.
I'm depleted, and I think, okay, that one sounds, and if I'm trying to pull things out, and if it's not driven by some anxiety, then it is just like a true postpartum depression. But truth be told, it's really, mental health isn't really, a mental illness isn't really black and white. Sometimes we have a few
little
different symptoms of a few different, quote, disorders. So I think depending on the presentation, the treatment can be a little bit different, but
well, how would you treat it? Like, how would you, let's say, like, a woman with postpartum depression, how would you go about treating that, or like telling her how to help herself?
Yes. Okay. So it is going to be individualized but generally, because sometimes giving them a list of things to do is not helpful, right?
No, like that's overbearing.
Yes, it's like, I can't do any of this.
Too much.
I'm going to fail, and
I'm going to stay in bed.
Yes, exactly. Yes. So just giving them a couple things to do, but also inviting in their support system, like what maybe the woman isn't sleeping, and so we start to talk about how could we protect your sleep. Do we need a medication to help you sleep? Which sometimes, you can do all the meditation and sleep stories and like
white sound, white music,
white, brown, green, like all these different sounds, and like I'm still laying here awake. And so do we need medication to support your sleep, which the brain needs that sleep for like recovery. So anyway, invite in the family or her support network. What can we do? You need a baby break. Sis, you got 6 kids, and your husband or partner is working 60 hours a week, and you're not getting a break from the kids, and you haven't had time to do anything for yourself. I mean, maybe you got a shower once this week because you wanted to make sure the toddler didn't sit on the baby. Like, there's just so much where the woman is going to need some support. If it's is there are validated screeners, that will give us a score based on their answers. And most people, once they see me as a psych provider, they're ready for some help, and so they're not going to underreport. Rarely do they underreport to me, but I know that happens where they're just like, I don't want the attention right now, I can't deal with it, so I'm just going to be like zeros on everything.
Yeah, and then you see them and you're like, girl.
Yes.
Yeah, it's all threes, okay?
Yes. But once usually they get to the psychiatric nurse practitioner, they're feeling pretty not good. And so you're like, all right, now.
True.
So I don't feel like I get a lot of underreporting, but so it'll kind of give me some structure on, okay, if their score is from this to this, it's mild, maybe we could just do some CBT and I'll refer them to therapy. And then we're going to work on sleep and baby breaks and trying to re-engage with some hobbies.
Yeah.
But if it's more moderate to severe, we're looking at probably needing a medication. And again, the medications are geared toward, if you think about SSRIs, we're geared toward serotonin. Remember, we're having less serotonin in the brain during the period of lactation. Because remember, estrogen is a little bit low. But there's other things we don't understand about the human brain and why things change and as much. But the treatment for anxiety and depression, first line is going to be adding that serotonin, because we know that can be very helpful. If we're treating anxiety, usually you need higher doses of serotonin. So your SSRIs are going to be dosed a little bit higher, whereas the more lower moderate doses can sometimes do the job for depression. But honestly, anxiety is harder to treat. And so now the depression can be absolutely dangerous with suicidality. So just because anxiety is a little harder to treat with higher doses doesn't mean one is more dangerous than the other. Like they're both need to be addressed.
Why do you feel like anxiety is harder to treat?
Well, I think, I don't know for sure, but the brain is just so active in coming up with all these different scenarios.
Like always wired.
Yes, and we don't want to, the idea is not, we want to, I had another fellow midwife be like, isn't the point just to like shut it down so she doesn't feel? And I'm like, oh my God, no, that is never the point. No, we don't want to shut it down.
Go back to school. Okay.
Like, no, we're wanting to find where she feels like her best self. Like, not ruminating and all these scenarios.
Right.
But I don't want her to be like, I care about nothing.
Like just be totally zero.
Yeah.
No, because that I heard from a lot of women. They're like, I have no feeling. Like I have no emotion.
Yes.
And you're like, okay, maybe we gotta dial back a bit.
Yes. Dial back, or we need a different med. Like there are some that are more notorious for flattening than others, and so that's an important decision-making piece too as a prescriber. But the point is not to make her brain just be not thinking.
Exactly.
But the distress or intensity of some of the thoughts and frequency, the goal is to tap those down so that she can then use some tools. So she's not like in fight or flight mode, but she can use some of the tools she's learning in therapy to be like, okay, do I need to give this thought that much attention?
Exactly.
Maybe not.
Which I think it is important for like all women to know, or like just all humans to know, that anxiety, like a healthy amount of it is okay. Like you don't always need to get treated for that.
That's right.
Like sometimes, you have like a speech coming up. Of course you're going to have a little bit of anxiety for that, right? So that makes sense.
Right.
So like we're talking about excessive amounts where you're ruminating, you're always like going into a thought, stuff like that.
Right. Moderate to severe it really does need to be treated. Mild, but almost every day still would benefit from treatment with some therapy techniques. But intermittent, stress-related anxiety, that's human.
Yeah, exactly. We all, cortisol, we all got it, okay.
And I will say one thing about OCD, by the way, on the treatment, how the treatment is different than like depression or a generalized kind of anxiety that's not very severe and debilitating. OCD actually responds really well to ERP. It's exposure response prevention therapy.
Oh, okay.
And so finding the right provider who knows how to deliver ERP is paramount in the treatment of OCD. So the OCD and Anxiety Treatment Centers, which are spotted throughout Utah, but also also are growing throughout the country. Certainly Recovery and Wellness, which, and for the podcast, I know you are having people outside of Utah listen, but they have an excellent program for OCD. And so with that, it's going to be pushing against that fear so that the fear has less power. So exposure response prevention is you're exposing yourself to that distressing thought and you're not reassuring your way out of it. Instead, like, let's say you are afraid of contamination in foods that are cooked at a potluck or a pitch-in, whatever we call it. Right?
Yeah.
And so what you would do in that case is the group would all bring some homemade cookies and you have to take a bite. Like, this is pushing against that fear. And so you learn, you know what, my world does not need to be small with all these rules to protect me. Instead, I mean, you still need to be reasonable, but this is the treatment. It is, you do it.
Right.
You do the hard stuff.
That's so funny you bring that up because people will bring stuff and they put it in the team's room on our unit, and I'm like, I'm not eating that.
Yes.
I don't know where this came from. I will not be eating this. That's so funny that you bring that up. But that makes sense.
Yeah. But and if you don't have OCD, then you don't have to follow this. I gotta push against.
Oh right.
You know
I gotta eat this.
Yes. Yes. Like,
I gotta find my brain.
Yes. But little sidebar. Work in LMD. Okay.
Yes.
This patient came. This is when I was an RN. This patient came and brought cookies. Okay. For the unit, because a lot of people do that. They're thankful for their
they're
care.
so nice.
Yes.
They're so nice.
And she's like, I made these with my breast milk, and they're all like, So that is different than, like, you know, pasteurized milk from Kroger. Okay?
Exactly.
Like, so that's different. Okay, you don't have to.
Which, I mean, there are benefits.
No, that is like a blood product. Like, we label it in the fridges at the hospital.
Seriously,
double label, right?
Yes, it's human fluid. Okay, we don't want to partake.
Anyway, but it's, you know, got a little off track there, but but exposure response prevention for the woman who needs to look at her phone to monitor the baby. She is going to delay that. That's part of the treatment. First is like, not that she can't ever check on her baby, but she's going to delay that, or she's going to allow herself to check once, and until she is like, you know what, this is just not a big scary monster in my mind as much anymore. It doesn't have as much power because I didn't train my brain that I need to worry about it by checking.
Yes.
Because if you check a lot, you're reinforcing that there is a threat. I better go check again. So that, and the other thing that a lot of people don't know about OCD is a lot of it is mental compulsions or these behaviors to give reassurance that you actually can't see. So like replaying a conversation, like, did I say that right? Did I do the right thing? Did I wash the bottle? Yes. So it's mental checking. Another thing that people do when we think maybe they're just playing on their phone, but they're researching. And ChatGPT has been wonderful in some ways for people to obtain information. But when it comes to OCD, the amount of deep dives people can take and then start to believe that, oh, I probably have cancer. Like if they have health OCD themes and they found a mass, if they ask enough to ChatGPT, they're like, you need an ultrasound? And you're going to have like chemo start next week. And so like
I've had like family of patients do that to me while I'm in the room. They're like, the internet told me this. And I'm like, well, the internet's not here right now. Okay, like, they have no idea what's going on. You can't even look at their labs. You don't even know what's going on with your dad, your papa. Okay.
Exactly. Yes. It's just taking a piece of information, whereas your healthcare provider has a bigger a bigger context to look at.
So mother that's listening, that's feeling overwhelmed, anxious, or guilty, or like she's failing, what would you want her to hear today?
First and foremost, this is that she's not alone. Like there's so many other people out there who've experienced similar feelings, and that there's help. And some stuff she can do on her own to help herself. But honestly, it is okay. It's normal to ask for help, to share. We've talked today about sharing your feelings and your thoughts and what you're going through with a trusted loved one. So she's not alone in experiencing this, and not to isolate herself by keeping it to herself. Like making an appointment with someone if she feels like, if she's having some scary thoughts.
Right.
And those scary thoughts may be about harm to herself, or it could just be these random thoughts that pop in her mind that she's like, why would I think that? And then she feels bad about herself. That's often happens with OCD. But other, those can also happen to anyone, even if you don't have OCD, an intrusive thought that's like, but just yeah. So reaching out, there's hope. And if she does have postpartum or perinatal, which means anytime during pregnancy, after pregnancy, depression or anxiety, that we're looking at 20% is what we're thinking is going to occur. So if you have 10 friends who go out to dinner to celebrate your birthday, you can feel pretty confident that 2 of them have had depression or anxiety. And that's if our reporting is correct. And so a lot of people are being missed. So
because I feel like a lot of people don't talk about it.
Right.
Yeah. A lot of people hide that.
Right. Yeah.
For sure.
Because like you said earlier, I should be happy, you know, and even people, interestingly, it's not that interesting to me because I almost expect it, but especially if they've struggled with infertility and they are finally pregnant and things are going well and they have this immense guilt if they experience some anxiety or depression. You know, they're just like, I should be so thankful. You know, we went through all of this. We spent all this money on IVF and just a lot of shame along with if they're experiencing that during their pregnancy. And so like you said, they don't want to tell anyone.
No, exactly.
There is this fear that somebody is going to think I am ungrateful, you know? Like I can't tell my mom because she's walked through this with me and she, as far as this pregnancy journey, and she might be like, well,
like, why are you feeling?
Yeah, what do you mean?
Perfectly healthy baby. You're fine.
Think about all your blessings.
Yeah.
Think about so-and-so who, you know, can't have babies. Those
Right.
things actually aren't helpful. Like, they're really not.
No.
And it is a tendency for people to say, count your blessings, and, you know, other people have it worse. That really invalidates your own experience that, yeah, people have it worse, but I'm suffering.
Yeah.
And so
Doesn't take away from my experience.
Right. We still need to share and seek help if it is becoming something that is making your world smaller, impairing your life.
Right.
Yeah.
Well, wonderful, Mandy. So just to close up, you are so good on mic. This is so good. I feel like so educated. But I guess just to close up, so I don't want to say like when your career is finally over, but because you have so much more to do is what it sounds like.
Yes.
You just keep going, which is amazing, and I just love seeing you thrive. So keep in touch with me for sure.
Okay.
But when someone, I guess, when your career is over and you decide to retire, if you ever do, if someone asks like who Mandy Christensen was, how do you want them to respond?
I don't know if it's gonna actually be reality, but here's what I want it to be. I want it to be, man, she was a badass advocate for women, in mental health, having people have access to care. She had some good ideas and really pushed against some traditional things that other people just felt like, yeah, that's just how it is. Yeah. Like I want to be known as someone who worked hard to help other people, in just their happiness. I'm not talking about they need to feel happy all the time, but just people deserve treatment for their mental health. They deserve to be respected, to have trauma minimized when it comes to pregnancy, birth. I want people to think about me and think, man, she fought for it and made some changes and helped a lot of people. That's what I want. That's what I want.
And that's what you'll get, girl, because I will say that. I will say that. Thank you so much, Mandy. I'll have to have you on again for like talking about so many other things because you are a whole thing of knowledge.
Thank you. I love it.
Yes. Well, thank you, Mandy.
Thank you.